All right, we are here once again for our next episode of Sebastian and Sierp. Welcome. We're so glad that you've come to join us to learn some nice things and meet with good people. Today, we are joined by Dr. Meriem Bensalem-Owen, and I hope I said Bensalem right. Is that correct?
Bensalem or Bensalem, it's okay.
Bensalem, okay. And she is here with us. She is part of the neurology program at UK, the University of Kentucky, and her field is epilepsy, right? That's
Yes,
correct.
sir, yes.
And so we're going to have a nice conversation with her about all things epilepsy, and you'll learn things that you knew already, and you'll learn things that you probably don't know. So welcome. We're so glad you could join us today, Meriem.
Thank you very much, Sir. Thank you.
So before we get into what you do, for people who may not recognize your accent, you grew up in Algiers, right? Is that correct?
Well, I was born in Algiers,
Okay.
and then I grew up partly in Algeria, so in Algiers, and then we moved to Italy. So I grew up in Milan until I was 17 years old, and then came back to Algiers.
Wow.
So I do have an accent, so it's not a specific accent.
So people
Some
wouldn't be
people
able to
think
recognize it
it's
anyway.
It's not a French accent. I do speak French, so my education is French. So my dad is Algerian, my mother is Bulgarian, and I went to the French school, so it's a mixture.
I see. Now, when was it you decided that you wanted to help people and get into medicine?
When I was in high school, the last years of high school, I wanted initially to be a veterinarian, and so I really wanted to help living beings, and then I switched to medicine.
All right. And now, was this when where were you living at that time?
In Italy.
Italy, okay. So was it in one of the Italian graduate programs you applied, or?
No. I just when I was through high school, so I decided to pursue a career in medicine. And the system is different in the French system because my education is French. So we don't have the college system. We don't have the 4 years. So once you finish high school, you go directly to medical school. So
Really?
the medical school is longer, though. It's 8 years of medical school, 7 to 8 years, depending if you're in France or other countries, but French-speaking countries. So it's it's a bit longer than here. But it pretty much includes college, but it's not called college. It's not separated into college and then medicine.
So are the first 4 years of a program like that, are they still in a preparatory way?
It's more preparatory, yeah. But you're directly in medical, so you really have to have an idea what you want to do pretty soon.
I was going to say, because in America we're infamous for being undecided for years and years as undergrads, but it sounds like a program like that wouldn't allow that.
You have to really be quick.
Right.
Decision,
you got to think fast on it.
Yeah.
So you went into medicine, but from the beginning when you went in, did you have epilepsy in mind?
No, not at all. I just had medicine. I just wanted to help people. And actually what I had in mind is going to join one organization and going to countries, either war-torn countries, or I really wanted to help and do that kind of field work.
So you wanted to do kind of a Doctors Without Borders type thing?
Yes, it's exactly what I wanted to do.
I see.
Yeah.
Okay. Now, so please pretend, you may know more than I do, but please pretend like I know absolutely nothing about epilepsy other than people have seizures. Okay. Okay. And if somebody said to you, what makes an epileptic, or what is an epileptic, what would you say to them?
Like an epileptic fit, or somebody who has epilepsy. So actually the definition, nowadays it's discouraged to say an epileptic person.
Is it discourteous to say?
It's discouraged. So we refer to individuals who have epilepsy as epilepsy patients, for instance, or somebody who has epilepsy. I do have patients that refer to themselves as I'm an epileptic. But just because it was felt that it has a negative connotation. But this is kind of a recent, trend. So have you ever seen somebody having a seizure, Jim?
I have, yeah. And it scared the life out of me.
It is. It's very scary.
Yeah, at Boy Scout camp when I was about 12 or 13.
Yes.
A friend of mine, Stuart, had one, and he immediately fell down on the ground, and he held his legs behind him, which I guess he had been trained to do if he started to have a fit, where he couldn't thrash around too much. And so literally he was on his stomach but holding his legs. So I took that to mean that someone had taught him to do that if he was feeling a seizure coming on.
Possibly, but usually with a seizure, actually, there is loss of body control. Seizures can present in different ways. What causes a seizure, it's an hyperexcitability of the brain cells, of neurons, the neurons.
Okay.
They're hyperexcitable. And then it can manifest with odd behaviors or sensations. So seizures can present in a variety of ways, depending which area of the brain is affected.
I see.
So some people can have very unusual seizures, epileptic seizures. For instance, if it's affecting the frontal lobes, they'll have what we call hypermotor movements. They're very wild movements. And actually, these patients, it's very difficult because they can be, even by somebody who's in the medical field, then be recognized as not having epileptic seizures.
Okay.
But they can present, for instance, if the seizure arises in the area that controls vision, patients initially may have a visual disturbance. That's how the seizure, but it's usually the same phenomenon that person will experience. Or if it's an auditory seizure that starts in an area that controls audition, they can have, they can hear things, either simple things, or they can have more formed auditory hallucinations. But this is just to say an example. But seizures can really present in different ways. So there are two big groups of epileptic seizures. And I'm just going to oversimplify it. Generalized seizures arising all over the brain all at once, over both hemispheres all at once. Or focal seizures where the seizure will start in one area of the brain and then it can spread, either remain there, or it can spread to involve both hemispheres, become generalized. But the onset, what matters to us is how does it start? Is it focal or generalized? Because this will determine the type of medications or approach or the choice of the medication that we'll prescribe for the patient.
So it's almost like a hurricane. So some stay in place and others move around.
It is. I mean, I tell my patients is that's having like a hurricane or some disaster, because this is what happens in the brain. There is like a natural disaster, but here we're talking about the brain. For instance, like an earthquake, you have the epicenter, and depending on the strength of that earthquake, it will cause more damage. So it will spread to involve more surface. For instance, if the seizure starts focally in a localized area. But then other type of seizures can start all over the brain all at once.
Now, is epilepsy something that's found to be genetic?
So there are a variety of causes for epilepsy or seizures. So some patients who have epilepsy can have a genetic predisposition. Some can have a traumatic. The cause can be traumatic. For others, it could be a tumor. Because what happens, it causes irritation to the brain. For instance, if we speak about a tumor, and it will lead to seizures. So the seizures are a symptom of that irritation of the brain caused by the tumor.
So I'm assuming there are cases where someone may go in they had a seizure that came on them at a certain age and they don't know why, and then they go in and through exploratory surgery or something, a tumor is found.
Yes, I mean with imaging, there are certain sets of testing that we have to do that. I think but the most important thing that we have, that as providers or physicians we have to do, is to actually obtain a good history, a good description. Sometimes, especially if we have witnesses that can relay what happened during the event, during the fit, then we can have an idea. Are we dealing with an epileptic seizure or something else that can look like a seizure, but it's not a seizure?
So sometimes the actual case history of whatever happened will be very, very
if we can
helpful.
have a good description or the patient can walk us through the symptoms they're having, it's very, that's a very invaluable information.
Big stuff.
And then we add more testing. Then we can add testing. Of course, we do the neurologic examination, general examination in the office or in the emergency room, for instance, if this is the first place where they seek care. And then we can order an imaging of the brain to make sure that there is no lesion that's causing this irritation to the brain and led to the seizures. And then we do an EEG, which is an electroencephalogram, which is basically recording brain cell activity. from the scalp usually. But we have different ways of recording electrical activity. We can be from the scalp, from the surface, which is non-invasive, or intracranially, where we implant electrodes in the brain. But this is for a subset of patients that undergo, for instance, epilepsy surgery work.
It has to be just for the right person.
Yeah, because
right
it's an invasive procedure, and there are risks with that.
Sure.
So it's usually if we want to gather more information, we can end up doing this in certain circumstances. But that information, we have to use it, for instance, for surgery. That's when we do this type of intracranial recordings.
So what is it about, like say someone had a lesion on the brain that had developed, what is it about that causes the excitation of the cells? I mean,
because it's not supposed to be there, that releases chemicals. Seizures are caused by chemical and electrical disturbances. So, and if there is something that's foreign there, it will cause irritation. For instance, blood. If somebody has a traumatic head injury and they end up having blood in the brain, that is very irritative to the brain.
So as the brain tries to repair itself, like if it's trying to get rid of a lesion or a tumor or brain bleeding or something?
It may not, no, we don't see, I see where you're getting, but it won't always cause a seizure. Some patients will have a traumatic event, even have blood in the brain, but won't have a seizure right then.
Yeah.
Sometimes it takes years for it to form, and then there is scar tissue, and that can lead to seizures later.
Well, I guess that's it was where I was going, and it was leading up to something else too, which was like if there's more electrical activity in a certain area of the brain, staying in one place or spreading out. Like say, for instance, you have an electrician who he puts his hand on a live wire, and then he gets shocked. Yes. Well, obviously all that current's going through the brain, but he won't necessarily seize as a result of it, right?
No.
That one, shut up. Okay. Thought I heard something over there.
It's got a timer on it.
Oh, okay. Yeah, sorry. So you see where I was going with that,
absolutely.
though. So,
yeah. But no, automatically you won't have a seizure from that. It can look like a seizure if you're electrocuted.
Right. I mean, if he's got his hand on the live wire and he's on the ground going, right. But that's different.
Yeah. And again, seizures can present in different ways, clinically or physically when we see them, when we witness them. Some individuals can just stare, just have a blank stare. Some individuals will convulse. And these are quite distressing to watch and very scary. They can turn blue, their lips can turn blue or purple. Sometimes they foam at the mouth, due from hypersalivation. And then they have these movements that they have no control over them. But usually during these episodes, their consciousness is altered. It's later when they recover, they feel the symptoms of having had a convulsive event, for instance.
Gotcha.
Sore. It's like running a marathon without being prepared to run that marathon.
So somehow when they get back to full consciousness,
but it's like the brain rewires and it's like reboots itself after a seizure. Gotcha. Not with every single seizure, depending on the type of the epileptic seizure, but with some seizures, the brain, especially when it's a convulsive seizure, also known as generalized tonic-clonic seizure, or grand mal seizure, yes. The brain is like having a huge storm, and then the brain just recovers and reboots after that. And so patients may act confused. Sometimes if we get too close to them, they may push because they may not recognize their loved ones, which is quite distressing also for the, or they can be perceived as being violent. Well, they're not really violent. They just perceive somebody whom they don't recognize as potentially dangerous or dangerous person, so they'll push people away. But it's not a directed violence usually. They're just trying to protect themselves. It's a very primal.
Like a fight or flight thing is triggered.
They don't recognize even their parents or their children. It can be quite distressing for families and loved ones to watch.
So I can see that a lot of the symptoms you're describing, because they seem like they're all over the place, like a lot of different ways
because
they
the
can
brain
present.
Is so complex.
Right.
And so
But I guess epilepsy gets convoluted with a lot of other things. Then I'm sure. In other words, if you see somebody who's maybe staring off into space for 20 minutes and you go, something's going on with him. Well, was it a seizure? Was it a stroke? Was it, a psychological issue?
It could be, and that's, we have the role of an investigator. We have to find out, when we get the history. If we have a good history, we can immediately say, we're dealing with somebody who has epilepsy or not, or had an epileptic seizure. So that's a little bit our job.
Yeah, it's like it's diagnosticians.
And then because not everybody who has a fit or abnormal movements has an epileptic seizure, or not everybody who's staring into space or having unusual sensations, visual or auditory hallucinations, for instance, has an epileptic seizure. But all these unusual behaviors or symptoms warrant investigation because it will determine, of course, the diagnosis, but then what the type of the management, the type of the treatment
Right.
that individual
Because you may be treating the
will
wrong
require.
thing.
Absolutely,
Yeah,
yeah.
sure.
We don't want to commit to a medication if it's not an appropriate medication, for instance, for the condition we're dealing with.
So something you said earlier to me was really intriguing. As part of our show, one of the things we're trying to do is take people with expertise like yourself, but then see how it's really affecting everyone culturally, philosophically,
Absolutely.
religiously, politically, whatever,
Yeah.
but see the overarching thing or the deeper thing that's going on with it. And something you said earlier about changing the dialogue or the terms with not saying having an epileptic fit.
Yeah.
Like, I guess, is there some shame with?
No, it's not. But there is that is. I'm really happy actually that you're bringing this up because
Right.
there's a lot of stigma around seizures and epilepsy.
But you don't hear about this. That's what's weird.
And we don't. And people actually who have seizures or epilepsy, they don't want to speak most of the time about it.
Sure.
There is an actor, Greg Grunberg. I don't know if you know the actor.
What's his
He
last
played
name?
in Elias, Greg Grunberg. He played in Elias. He played in Heroes. And his son has epilepsy. He's very outspoken about it. And he actually has this organization called Talk About It. And it's Talk About Epilepsy. Because the more we speak about it, the more, hopefully, people will be more knowledgeable about it, and also it will diminish the stigma that surrounds epilepsy and seizures. And this is something that's not in one particular culture, but it's a phenomenon that we see in a variety of cultures throughout the world. Patients who had seizures or epileptic seizures were considered to be possessed. And families were, they tended to be hidden away, people were ashamed of them. Because as you said yourself, if you see somebody having especially a grand mal seizure, generalized tonic-clonic seizure, or convulsive seizure, which is the same term too, it is very scary. And actually this can lead, some maybe then, if it scares you as a human being, you don't want to be around people who have seizures maybe because you don't know what to do. It basically shows you a vulnerability. You don't know what to do, and it's like, I don't want to see this again subconsciously, okay?
Sure.
Because I wouldn't know what to do. So then there is social isolation. I mean, this has an impact also on individuals who have epilepsy. They tend to isolate themselves because they're embarrassed of having a seizure in public, of losing control of their body functions.
That's going to be my next question: is do they tend to not have antisocial behavior, but just
some,
secluded?
Yeah, some tend to be, but no. I mean, we have my colleagues and I, and there are individuals who have epilepsy who are having a fulfilling life. They're able, especially if the seizures are well controlled and they have just to take their medication, or maybe they had epilepsy surgery, for instance, and they're cured from their seizures, and we take them off their medications, or maybe not take them off their medications. But if their seizures are well controlled, they can have a fulfilling life. They can have a job, they can go to school, they can have a family. Now, even if they're poorly controlled, we have individuals or patients who are poorly controlled with seizures, but they still can have a family, they can have a job, but they have other challenges that somebody who doesn't have epilepsy would never know.
Sure.
But it causes a lot of anxiety, a lot of depression in some individuals, especially if they're not well controlled. They can have side effects from their medications. So we have to be mindful. It's beyond just the epileptic event itself with the epileptic seizure.
Sure, it affects all these different things.
And then it has an impact. I mean, one of the impacts that people dread the most, I mean, of course, it's fear of injuries from seizures, but also driving, because there are restrictions. And depending on the states, some states have more, they're more restrictive with driving. Some individuals who have epilepsy have to be reported as having seizures. And so it has a lot of impact. And then you can't, And it can be from anywhere from 3 months not able to drive, from the last seizure, to 6 months to a year. So can you just imagine how, you can't go to work, you can't go to the grocery store.
So you're saying if someone's driving and they have a seizure, and then it gets reported or they report it, then there's a stipulation of you can't drive for this amount of time?
And depending on the states, yeah, absolutely. And depending on the states, yeah.
Wow.
Yeah.
But since seizures are so erratic and you can't predict when they would happen, that seems like a bit of a false...
The time, yeah, that's true. Most of the time they are, and that's true, they are unpredictable. And that what is really, really scary, because they can really affect individuals at any time, anywhere. But there are things that can be prevented. Now, not everyone who has epilepsy, if they're well controlled, as long as they take their medications and do avoid certain situations, like for some people that can be sensitive to the lack of sleep, can trigger seizures. Not everyone, but some people can be quite sensitive to the lack of sleep. Caffeine, especially if it's excessive, but alcohol, for instance, alcohol can
is that a big trigger?
Can trigger in some individuals, can trigger seizures. Some people can have alcohol withdrawal seizures. It doesn't make them having epilepsy, but it's a different category. But some patients who have epilepsy, if they drink alcohol, it may induce seizures, for instance. If they don't take their medications, that's the number one cause of breakthrough seizures in somebody who has epilepsy. They don't take their medications, and sometimes, we're human beings. It's so easy to miss a medicine.
Sure.
But the difference of missing multivitamins or even a cholesterol pill for a week, it won't have the same implications as missing not even a full dose of anti-seizure medicine for the day, maybe half of the dose, let's say the morning dose.
Yeah.
So the
it's
implications
not like fish oil
are
or
much,
something.
absolutely, the implications are greater.
That can really...
And then there is not just the risk of not being able to drive from the last seizure, but there are risks of injuries from seizures, falling from, can you imagine you have a seizure crossing the street?
Sure.
And it just happens. Or taking down the stairs, going down the stairs.
Are there any states that prohibit epileptics from driving entirely?
No.
No.
No, unless if they're not well controlled, then they can't drive.
Yeah.
And it could be a lifelong no driving. Some individuals who have epilepsy, people who have epilepsy have never driven actually. And unfortunately, they may never drive because
how does insurance handle that though? Because it looks like you'd have to report it to your insurance when you get insurance, and then if you were to say have a severe wreck and even kill someone while you're having a seizure. Not to get too weird and heavy with it, but I could just see that being for an insurance company, like we're not paying anything, and then that could wreck the person's life in a lot of ways.
Rethink your entire life.
So
I think the main thing we deal with insurance companies is approval of medications.
Right.
And so we have to.
But don't they ask you that?
The legal aspects,
right.
So sometimes we have to put a little bit of a fight as physicians or providers.
Sure.
To get medications approved by insurance companies. Sometimes they dictate what medicine we should be prescribing, which is, and I'm not going to be politically correct here with insurance companies, but which is, as physicians or providers, we will do whatever we feel is best for our patients. But sometimes we feel that we're told what to do. And of course we have to be mindful, about the cost of medicine and the cost of certain medications, but at the end of the day, if somebody is seizure-free from a medication, why switch them to a different medication?
Right.
Because that's priced as being seizure-free.
Don't fix it if it ain't broke.
They can absolutely have a job, they can drive, they can,
Well, even for people who may have epilepsy, but maybe the physician's not even involved. Just taking the physician out of the equation, and they have epilepsy, but they just decide, I'm not going to do any medicine. I'm assuming those people are out there. And
yes, I'm sure there are. They won't listen,
and so if they,
care.
it just looks like that could set them up for some horrendous insurance issues regarding driving or
Independently of insurance, I mean, I think that there is a big liability
yeah,
for themselves and
or
others.
just killing,
If they're
dying
driving
in a
and
car
not taking
accident,
their medications, yeah.
or
So it can
operating
be-
heavy machinery if their
Oh,
job requires it.
absolutely.
Wow.
Flying a plane, or could be.
Of course, you may not know.
Yes, yeah. I mean, if you don't know, or you don't know what is wrong, it's one thing. But if you know and you're not doing what's recommended, medically recommended, it has
Now,
more implications.
That's something else I was going to ask you regarding when seizures start. Is that just any age, any time? We don't know why. What happened?
Very good question. Yeah, actually, it can happen at any time,
Wow.
even in the woman utero. So
in
fetuses
utero.
can have seizures. Yeah, in utero. So
Wow.
there are it can affect anyone at any age. There are the two big groups really where we see the highest incidences in children, actually less than 5, in adults above elderly above the age of 65. But it really affects, and the causes can be different depending on the age. Every age can have multiple different causes for epilepsy, but certain causes are more frequent in one subgroup than others. For instance, brain tumors won't be as usual in maybe a young adult.
Mm-hmm.
They may be more frequent, or if somebody has a stroke, that can also lead to seizures. If somebody has a stroke, we see strokes in children, but it affects really mostly elderly individuals. So that can lead to
So
seizures.
strokes will lead on to that.
Not everyone who has a stroke, but because again it causes irritation.
Yeah, so it's
To the
so the
stroke
irritation
itself,
is the
yeah.
thing.
The
Right.
symptoms of a stroke sometimes can be mistaken. The symptoms that lead to it or are associated with a stroke, and the symptoms that are with seizures, sometimes they can be mistaken. But just to have again a simplified vision, a stroke is a loss of function in the brain because there is destruction. I mean, I'm simplifying it. Destruction could be, let's say, a stroke where blood is not getting to a certain area of the brain. So that area that has a certain function may not function well.
Mm-hmm.
With seizures, it's the opposite. It's an excitability of that area. Seizures cause excitation. So instead of losing, for instance, function of the arm becomes weak. The arm
becomes
can
like
be jerking or
Incredible
become So
Wow, that's amazing. So when you're assessing someone, like say for instance, parents brought in their 5-year-old son, and they said he the other day he was staring off into space for a half an hour straight, and we don't know if there was something neurologically going on or if he was just daydreaming, but it was really weird and he didn't seem to be able to hear us. What would you do from there?
Yeah, well, then you mentioned the duration, 30 minutes. That would be unusual. Usually seizures last a few seconds to a few minutes.
So that right there would tell you.
But there are instances, and it's called status epilepticus, where seizures can last several minutes, more than 5 minutes, sometimes hours. But as a rule, seizures are brief, a few seconds to a few minutes. Of course, if somebody witnesses a seizure, especially if it's a seizure where there is a lot of movement, or the patient, the individual turns blue around the lips, which is quite distressing to watch, it's, we tend to feel that it lasted longer than what the actual event lasted. But from there, let's say the parents feel that their child is having these brief episodes, several a day, for a few seconds, where the child is distracted, stares into space. It could be just inattention, but it could be seizures. And then one of the tests that we do is an EEG, a brainwave testing, the electroencephalogram. It's electrodes placed on top of the scalp, and we record for like 20-30 minutes. And that sometimes we can catch a typical event. Sometimes we can do procedures to try to capture an event. And we do that in the EEG laboratory, where we make patients, breathe. Provoking factors. It's called sudden unexpected death in epilepsy. It is sudden, it's unexpected, and it's not caused by the use, let's say, of drugs. The toxicology postmortem is negative, and there are no structural lesions when the autopsy is made. Yearly, we feel that there is probably 1 in 1,000 individuals with epilepsy who may die from
I think I read that in some of the stuff you had sent. Yeah, that's pretty disturbing. Yeah,
It is scary. I mean, it's not, it is.
It reminds me of a sudden infant crib death. Yeah,
Yeah.
I mean, that would be a horrible thing for parents to have to endure. Well,
Parents or loved ones, I mean, they.
sure.
Yeah.
So, I'm assuming that there are a lot of support groups for epileptics. You want to talk a little bit about that? Because, I mean, for someone who's watching, maybe this is affecting you in some way or a family member, and this would be good information for you. So.
Yeah. So no, thanks for asking. Yeah, there are support groups. So there is at the national level, there is the Epilepsy Foundation, but then there are so many different groups. In the state of Kentucky, we have the Epilepsy Foundation of Kentuckiana, which observes Kentucky, but also Southern Indiana. And we work closely with them. They're very active. They do a fantastic job. Last month, they just had an epilepsy walk throughout various cities and towns in Kentucky. So the Epilepsy Foundation of Kentuckiana is very active regionally. But then we have our local support group at the University of Kentucky. So yeah.
So UK has a.
So UK has our own. Once a month they meet here at the University of Kentucky, and it's led by our epilepsy nurse coordinator Rachel Ward Mitchell. So hope she'll see that.
Say her name one more time. Rachel.
Rachel Ward Mitchell.
Rachel Ward Mitchell.
Yes, and there is a support group. So there is a Central Kentucky support group. She leads that group as well with patients. So it's a patient also led group, which is fantastic.
Right.
Patients and their caretakers. Some of the caretakers are involved with the support group.
So they can go in and say, "Here's what's been going on for me."
Absolutely.
Led in that way.
Yeah, absolutely. And we can share information about their Facebook page and ways to contact.
Well, I think if you all just go to the. Would it be the
epilepsy?
Epilepsy.
The Epilepsy Foundation of Kentuckiana does a wonderful job. Also, at all the events, even the support group that we held once a month, that we hold once a month here at the University of Kentucky, they usually advertise that on their webpage.
Okay.
So their executive director, Deb McGrath, does a fantastic job with her staff.
Gotcha. So if you all are interested in there, dear viewer, please go and check out the University of Kentucky, the Epilepsy Foundation, and you'll for sure get the information that you need. We're going to take a short commercial break. We'll be right back with Dr. Miriam Bensalem-Owen. At Kyojuteru Kempo, we believe that everyone has the right to defend themselves and their loved ones. Violence can visit us despite age, race, or gender. Call us at Kyojuteru Kempo or check us out at kyojuteru.org. kyojuteru.org. Hello, I'm Chip Sebastian. I am the co-host of Sebastian and Sierp. If you've been liking the shows, please click like down below. And if you want to subscribe to our YouTube channel, jump on over to YouTube, click subscribe, and you will get the most recent episodes of our show where we're interviewing all kinds of great and interesting people. So we're looking forward to a lot more shows. Stay tuned. It's rolling. Just begun. And we're back. And I know the commercial was so short, wasn't it? It was a quick commercial.
Can we do that again?
That's just what we want.
Can we do it again?
And we're back.
Oh, we're back.
So you need one like that. And we're back. Something good like that. Yeah, I'm not trying to chase you away, viewer. Okay. Anyway, I wanted to ask. I know that you do a lot of clinical work and see a lot of people, but there's a research side to your work as well, right? Is that correct?
My colleagues and I were primarily from the epilepsy group, the comprehensive epilepsy group at the University of Kentucky. We are primarily clinicians, but we do also clinical research. So we do research, but it's clinical research with investigational medications that are yet to be approved by the FDA or are already approved by the FDA, but we're looking at different other outcomes. And then with investigational devices too for epilepsy.
So these are like stimulators or electrode type
right.
things? Yeah.
Currently, there are 3 neurostimulation devices approved by the FDA. The vagus nerve stimulator, the responsive neurostimulator, and the deep brain stimulator that was most recently approved by the FDA.
So with the vagus nerve one, the first one, in what instance would you all give that to someone or to recommend they use that?
Any type of neurostimulation, or when we discuss, because those are surgeries for epilepsy, not resective, where we remove the area of the brain that's causing the seizure, the source, but with neurostimulation, but they require some sort of epilepsy surgery. It's not brain surgery for the vagus nerve stimulator, but for the deep brain stimulator and the responsive nerve stimulator, that requires brain surgery.
Okay, so literally they would.
And the mechanism
Go
is a
in.
bit different, the targets are different, but the idea is the same in the sense that we disrupt electrical activity with electrical activity.
Got it. So just like current.
Yes,
flowing.
either indirectly, it's not painful, but either indirectly with for instance, the vagus nerve stimulator, which sends stimulations periodically, and then the most recent model can detect heart rate changes.
So much like a
with seizures.
pacemaker would, in a sense.
Yes, especially when the heart rate goes suddenly up, it will detect that, assume it's a seizure, and then send a stimulation.
So with any epileptic, I know there's the wide range, but will that always show a difference in heartbeat
Yes.
or a dysrhythmia or something like
absolutely,
that? It
yeah.
will, okay.
So the most frequent type, and that's a very good question actually, that's the seizures can affect the autonomic nervous system, and the most frequent manifestation is a heart rate increase, and the heart rate with seizures that we see. But some patients can have other types of arrhythmias, a variety of types of arrhythmias. Sometimes it can slow down the heart rate. Seizures can slow down the heart rate, and sometimes it can make the heart stop, what we call asystole, which is very frightening because sometimes we monitor patients who have epilepsy to try to understand their type of seizures. So we have a monitoring unit, they're admitted, we have a video, and then we record their brain waves at the same time, but we record the heart rate as well. And sometimes we have these unexpected findings where somebody has a seizure, but then the heart stops from the seizure.
Wow.
Yeah.
Wow.
So it has different implications. So one of the mechanisms, there are a lot of theories about what, for instance, we mentioned sudden expected death in epilepsy or SUDEP. Some scientists and clinicians feel that maybe the cause could be that the heart rate is affected by the seizures, or the respirations are affected, and this can lead to.
So if we saw someone having a fit and then they passed away upon autopsy, you might find that it was actually a heart attack that killed him, or something
There
other
are
than.
changes in the heart, but then it wouldn't be SUDEP.
So the SUDEP has to be.
Some patients can have also a variety of medical conditions. I mean, they can have epilepsy and they can have cardiac problems. That is to determine if it's a cardiac, if the origin of the death is cardiac, then we can't call it SUDEP. Sudden expected death in epilepsy.
Okay, it's very specific in that regard.
It's very specific, yeah. That means we can't find a reason, but we know, unfortunately, the death happened around a seizure. Usually.
Gotcha.
Yeah.
But if someone had, say, high blood pressure,
Yes.
and maybe they hadn't been taking their medication, but then they had a seizure that could affect that in such a way that it could lead on to death. Because
it can get quite complicated.
Right. That makes complete sense. So with the just going back for a minute to the image of epileptics in our society, I remember when I was a kid, it was always kind of a thing to that Valley Girl term, "gag me with a spoon."
Yes, that's no.
Right.
Yes.
But I remember growing up and hearing that,
sure.
and I'm assuming that it started as like a mean thing to say to somebody, but then it got into the sort of Valley Girl slang and became kind of meaningless. Do you know what I mean?
Mm-hmm. Yeah.
Because it was just being said everywhere,
Is that right?
and you might not have anyone with epilepsy in 20 miles of you, but you're saying "gag me with a spoon," right?
Yeah.
But the idea of
So I was not familiar with this expression.
Oh, really? Okay.
Yeah,
Okay.
that is interesting.
Well, like,
Hopefully nobody's using it now.
do you remember Valley Girls back in the 80s? Do you remember that?
No, I don't.
Okay, so in American...
I grew up in Italy.
No, I understand. You probably didn't have it there. But in American culture, there was a phenomenon called the Valley Girl. And so for probably about 5 or 7 years in the 80s, young girls were, running around with a certain type of clothes that people wore in California, mainly, Valley Girl, the Valley. And they had all these expressions like gnarly and gag me with a spoon, and it went on and on. So this became a whole other language, like a subculture for a time.
Interesting.
But then I remember thinking as a kid that gag me with a spoon sounded like something mean to say that became part of their lexicon. Does that make sense?
Sure, yeah.
And so my question was going to be, what is the significance? I mean, did it used to be the case that spoons were used to keep...
Because actually and it's, so my first thing would be, do not put anything in the mouth of somebody who has a seizure, an epileptic
So just
seizure.
bad idea.
Don't put
Especially
anything.
your finger trying to get a finger bitten off or something.
Yeah, so, and the spoon, I mean, they can break their teeth, so it has a lot of...
So bad idea. So
bad
that's,
idea, no, bad idea, and that's the first thing we tell patients, don't put anything.
See, they used to say that years ago.
But this is across different cultures. It's not just in the United States, but in other
Mm-hmm.
cultures, the same thing. The first thing is like, oh, you need to put something in somebody's mouth who has a seizure.
Yeah, bite down.
Because the thought is, because you feel so helpless, and you're like, okay, what can I do? At least I can help them not to swallow their thumb. But they will never swallow their tongue. The tongue is fixed. There is nowhere. But that's true. It can get into the way, and patients who have a convulsive seizure, for instance, can bite their tongue, but because they have these repetitive movements of their jaw, so if the tongue is in the way, they may bite the tongue. And we can have patients who have severe lesions of the tongue just from these repetitive clonic facial movements. But the best thing is not to put anything in anybody's mouth.
All the time.
I'm sorry?
You see it in movies all the time, anytime.
You see that, yeah, because I mean, it's still a cultural thing, but yeah, we should not be.
So it's really a misrepresentation.
Misrepresentation. I think the main thing is if somebody, for safety reasons, you witness somebody having a seizure, his first thing is not to panic. But everybody will panic. Even physicians will panic, especially physicians who don't see seizures all the time, or nurses or people from the medical field will panic. So it's not unusual for somebody who's not even in the medical field also to panic. It is frightening to see somebody having a seizure, but the main thing is not to do anything that can harm them. So if they fall on the floor, and if you see them having repetitive, let's say, head movements on the floor, maybe put something soft between the head and the floor so they can protect their head when they have these repetitive movements, and not put anything in their mouth. To turn them on their side. We recommend, we do this also in the hospital, in beds, if a patient has a seizure, an epileptic seizure in bed, the nurses know to turn them on their side. And one of the reasons we do that is because some patients can have hypersalivation, or they can have foaming in the mouth, so all the drool will just come down. Instead of swallowing it, because that can cause aspiration pneumonia, for instance. They can end up having pneumonia just from aspirating that extra saliva.
That makes sense.
And then time it. Usually seizures last a few seconds to a couple of minutes, but of course when you witness an epileptic seizure, it's very frightening, and time kind of slows down, and so we tend to overestimate the duration of a seizure. The recovery phase actually after a seizure lasts longer, sometimes several minutes to several hours before patients recover. Their brain reboots, their brain cells reboot, and they are back to their baseline.
And the body's probably just tired, isn't it? I mean, it's just it's
tired,
depleted.
Mentally, physically tired. Yes,
Right.
depleted. Yeah, that's.
Well, it would seem too that if you saw someone and the foaming at the mouth was going along with it, if it was medieval times, that would really make you think like the devil is in them or something.
Yeah, I mean, and patients,
and feed into that.
And unfortunately, that's so there is this misbelief,
Mythology built up around it.
It's
not understandable.
Individual, unfortunately, that with epilepsy were possessed, but they're not. They're not. Their brain is just hyperexcitable. And one thing is really anyone who has a brain can have an epileptic seizure.
Yeah, there's science behind it.
You have to, and anyone who has a brain, so can have unfortunately an epileptic seizure. Just can I ask you a question?
I'd love that.
Yeah, Chip. So, how many? What do you think is the frequency of epilepsy or seizures or epileptic seizures?
with an epileptic, or you mean
Yeah,
in
let's say in the United
population?
States, what is the, how often do you think we see, what is the frequency or the incidence of epilepsy, or how often, is it a frequent condition? What is your perception of epilepsy?
My perception is that
Fill in to Chip.
it's
Wow.
yeah, I guess I don't. Aside from the one I mentioned, that's the
Yeah.
only one I've seen. So I'm going to say it's infrequent. But then I've got a feeling you're going to tell me it's very frequent.
Well, it's not. It's not infrequent. It's not that infrequent. So epilepsy is the fourth most frequent neurological condition
Okay.
after migraines, stroke, and Alzheimer's disease.
Okay.
See, but we hear about other neurological conditions, which is, I think, great because it raises awareness. But we hear about other neurological conditions more often than epilepsy. Is that right? And I'm sure you can.
We certainly hear
name
about migraines
several.
more.
Yeah, migraines, that's true. Migraines, yeah. But you can hear about other neurological conditions. You hear about multiple sclerosis.
Sure.
You hear about Parkinson's
Parkinson's,
disease, about Lou Gehrig's disease.
Yeah,
You
peripheral
hear about
neuropathy.
so many. It's quite frequent too.
Yeah.
But you hear about all these neurological conditions, and there's so many more. But you don't hear as much about epilepsy.
Why is that?
Yeah, stigma again. Most
It's
likely.
a
Most likely.
stigma.
Most likely. And and I think the more people speak about it, the more I think it raises awareness
Mhm.
and hopefully funds for research. And this is the way I see it, because I see with other neurological conditions, they may have more support financially.
Mhm.
I hope, and I'm saying this, it's advocate for my patients and for the condition. So I hope that we can raise more awareness, and so we can get more funds for research, because that's what we need.
In case
Find
any
a
of you
cure.
missed that out there in the audience, what she was saying was is that
please.
she needs funds for research.
Not me, all my colleagues
All
and
of
my
her
patients,
colleagues,
and
her
so we
patients.
can improve the lives of individuals who have epilepsy. So to
Absolutely.
get back at the frequency, in the United States, 1 in 26 Americans will have or had epilepsy or seizures in their lifetime.
1 in 26.
Yes.
That's a lot more frequent than I would say.
Is it something that ever resolves on its own?
So sometimes, yeah, that's a great question. So certain epilepsy types will subside, and we see that in childhood. Some of the epileptic types can subside in childhood, that we say kids outgrow them. Usually when epileptic seizures happen in adulthood, they won't just go away. Unless we do an intervention. One intervention would be epilepsy surgery if the individual is a candidate for that.
I see.
And if we can do a good job by localizing the source of the seizures. So some individuals can outgrow their seizures, but that really happens in childhood. In certain epilepsy types in childhood, unfortunately, some children have devastating types of epilepsy with numerous seizures a day, and unfortunately, it can affect their development as well. So it's more than just the seizures that are distressing to witness by their parents and their family, loved ones, but it's beyond that. It can affect the development of the child.
Well,
It's like having your brain under siege all the time being attacked.
I was going to ask you that too, because it seems like the really frightening nature of seizures to the people around is so disruptive of our social engagements and interactions. Do you feel that that's why there is such a stigma with it? Because I've noticed that with other conditions, like for instance PTSD. If you have someone that's, whether they've been in war or whatever, they have that, and then all of a sudden they just can't function socially in a certain capacity. And then they start to get ostracized, or they feel ostracized. And as a result, people think, oh, you have PTSD. There are people who are kind of afraid of those people. And then there are also people who are afraid of, not so much anymore, but like when I was growing up, anyone with multiple personality disorder or schizophrenia, they would think, well, that's, you're possessed, or it's because they're just not functioning in the way we're functioning right now socially, in the way we've learned
I
to.
feel that sometimes I think we're frightened when we don't understand what's happening. I think if we're
So it's
knowledgeable about a condition, for instance, I think we feel that we have a better understanding, then it's not as frightening. So I think one thing is to get educated.
Yeah.
Sorry.
So ignorance-based fear is what you're
Yeah, there is, it generates fear. But I think, when somebody witnesses a seizure, especially if it's a grand mal seizure or convulsive seizure, or again, jealous tonic-clonic seizure, it really, you want to do something, but it's so frightening and you don't know what to do, and it reminds you how vulnerable you are as a human being.
Mm-hmm.
I feel that way. I feel that, because we can know the theory also, so we know, even as I mentioned earlier, I hope I'm not getting into trouble with my colleagues, physicians or nurses, but as I mentioned, some physicians who maybe have seen one seizure, never saw a seizure, they can know the theory behind seizures and can study seizures for their test to become a physician, for instance, but when they witness one, it's just very different. Again, it depends what type of seizure they'll witness, but if they witness one, it can be quite frightening, even for somebody who's in the medical field.
Mm-hmm. Well, that seems
and
to
then
be...
not that we get used to them. We see seizures. We sometimes induce seizures to try to understand them in patients who continue to have them. So my colleagues and I, in the epilepsy program, we tend to do that. But again, we don't induce seizures in somebody who's well controlled. It wouldn't be ethical to do it. But if somebody continues to have seizures at home, might as well just see what's happening at home. Sometimes we have to bring them in the hospital. We record the seizures in an environment that's supervised and well controlled, and we have protocols for that. And it's called the Epilepsy Monitoring Unit. So we try to understand their epileptic seizures that way. Or sometimes we find out that they're not having epilepsy. They're different type of events.
Turns into something else.
Yeah, paroxysmal events. They're different, but they're not epileptic. But it's interesting. Again, it can manifest themselves, seizures also, or events in different ways. But if we can make the correct diagnosis, then hopefully we can help our patients better.
Right.
But again, we tend to see seizures it's always, and again, when we try to record the seizures, we have to be mindful because there are always risk of injuries. Mm-hmm. We discussed, with seizures, with SUDEP.
Sure.
So we do it in a controlled environment, but we have to be mindful of the risks when we do this kind of job. But we don't become blasé about it, but we see more often seizures, so we feel like, okay, hopefully we know what to do. But even if physicians have never seen seizures, they may be like, oh my gosh, it's very, very frightening.
Well, it seems to be a common thing with a lot of subjects medical, where people who haven't gone through training to be an MD or PhD, or even in some cases, a social worker, something like that, people who haven't done that a lot of times assume that anyone with the initials after their name, they just kind of have this general knowledge of everything, when in fact it's just not the truth.
We can't know everything, but as long as know your limits.
But I think that's the perspective with a lot of people.
Yeah.
Like, in other words, you may be a doctor that focuses primarily on epilepsy, but hey, let me talk to you about my bunions. Right? And and then you're like, bunions? I don't know anything about bunions. I didn't study to do bunions. And you're a doctor though, right?
Yes.
But that's the mentality, it seems, a lot of times.
It is, but I think, I think we have to remind ourselves we're all human beings. I'm just going to give an anecdote about myself, a personal anecdote. My son had seizures with fever. So he doesn't have epilepsy, but maybe I should not be speaking. I have to ask him his clinician. Maybe I'll cut this.
That's okay. Yeah.
He's 15. He may not, want to know people. But just we're not going to cut this.
Or similar anecdotes.
But just give an example. Like he when he was younger, it was not with a seizure, but he was a neonate, newborn. Just came back home. He stopped breathing. He turned blue on me, like blue, and he was limp, and he was lifeless. And, and actually my mother, I'm a doctor, okay? But I'm a mother. You have this child, just gave birth to this child. And my parents well, Aiden stopped breathing and he's lifeless. And I was, getting ready to my appointment to the gynecologist after the delivery because I just came back home. And they bring me this child, my baby, he's lifeless, he's blue, and he's gone, And then I tell my dad, call 911. He was like, you're a doctor. See, but but
Right.
then I'm a mother. I'm not a doctor anymore. Does it make
Sure.
sense? Yeah.
Well,
So-
you might have been in such extremists, it would be hard to do the.
I know, but
Proper
yeah.
thing at that time, so.
My dad was like, "But you're a doctor. Why would you call 911?"
Yeah.
Yeah.
Well, but yeah.
But with seizures, he had seizures. Then I'm like, okay, what do I tell? Because even if it's your own child, of course, we're not recording this. When he had this, he had one time he had a long seizure. He turned blue. So I see seizures all the time, but it's your child,
Sure.
you know. And but then I was like, okay, what do I tell my patients? I tell them, don't panic, time it,
Mhm.
and make sure they're safe,
Yeah.
But that's the main.
Like the mother
you know,
thing overrides
the mother
doctor
thing, yeah. But we're not recording here. But I have colleagues like big surgeons, and they're tough, and they play tough. They see a seizure, they totally panic, they freeze, and you're like, wow,
It's like an elephant with a mouse.
That's what I'm saying. Exactly, that's what I'm saying. So yeah, it is frightening.
that's
Sorry,
funny.
we went off on a
That's
on a
okay.
thing,
And
sorry.
we're back.
We're back,
We're
sorry.
recording now, folks. We're going to take a short break here, and we will return once again to talk more about epilepsy, the Epilepsy Foundation, and the many, many, many ways that you can contribute your hard-earned dollars to help Miriam in her cause for epilepsy research and treatment. We'll be back. And we are back. So, how long have you been here at the University of Kentucky?
Probably for a couple of decades now. I stopped counting.
A couple of decades, yeah. So, and for those out there who don't know, the University of Kentucky is very much a research school, and so we have a lot of what I don't think I'd be false in saying it's a cutting edge university in a lot of fields.
We have, and then we have great doctors, great scientists, and
the first,
but
first artificial heart was here.
But there are a lot of things,
Robert Jarvik, right?
There were a lot of, we have colleagues that do an amazing work, scientists and clinicians. But I think one thing we have to remind ourselves, first, it's an academic center. So as an academic center, we are expected to do research, to do avant-garde, treatments, propose at least. But I think one thing we have to remind ourselves is that it's a group work, it's a teamwork.
Mm-hmm.
So for instance, for epilepsy, we work with colleagues that are not all epileptologists that specialize in epilepsy, but we have neuropsychologists, neuroradiologists, we have neurosurgeons.
It's cross-disciplinary.
So it's a multidisciplinary approach for our patients. We have nurses, we have EEG technologists, so it's beyond just the physician. It's a team, and we wouldn't be able to do the job we're doing without this wonderful group of people that support us.
So
and
no I in team.
Absolutely, and everybody has one focus, is the patient.
Mm-hmm. Sure.
And hopefully we can improve the lives of our patients who have epilepsy.
I did have a question about, has epilepsy been linked to mental disorders at all?
Well, that's a good question. There is a higher risk of, it goes either way, but there is a higher risk of anxiety and depression in patients who have epilepsy compared to the general population. If they don't have epilepsy, and because of a variety of reasons. I mean, you have seizures, especially if they're not well controlled, that disrupt your life.
Mm-hmm.
You had plans in life and you can't accomplish what you wanted to do in life. You can't drive, for instance.
So it's not necessarily from the chemical process itself, but from what it creates.
But it can go either way. I mean, it can go either way, but it could be from medications. Some medications can also, anti-seizure medications can increase the risk of depression.
Gotcha.
But then, imagine living a life of fear. You don't know when you're going to have that seizure, so it causes a lot of anxiety.
Mm-hmm. Yeah, it's like it's always knocking on your door, and
you just don't know when.
When's it going to show up?
You just don't know when. Yeah. So it has a lot of implications. Social, psychological, physical.
Yeah.
So it affects the individual, the families. Imagine having a child who's sick, chronically sick. And family, society, the community. I mean, it has a lot of implications.
Well, I can, of course, I can see how devastating it'd be to have your child have that going on, but I could see it being for some people, maybe a very shameful thing, or the feeling of shame if they were a parent and their children witnessed them having.
There is.
You know.
And some of them actually have children who they teach their children what to do. If the
Oh,
mom or
that's
dad
good.
has a seizure, so you have these children who they become more mature, responsible at an early age.
Like if this
They
happens,
understand because
this
they become the caretaker.
caretaker. Wow.
Not when they're very, very small, but they become that way.
You also have service dogs that
Yeah, that is interesting.
can actually alert
yeah.
you before one comes on.
Yeah, sometimes if they're well trained, I mean, it's debatable, but I think, we heard amazing stories about these service dogs.
So
but I
do
think
they sense it before?
they can sense some, dogs can sense. I mean, there was a story I heard a story, I don't know the child, but I heard the story about a child who had a dog, a service dog for epilepsy, in the class. And one day the dog leaves that child and goes to another child. And the other child had his first seizure ever.
That's nice. Yeah, that's really, yeah.
I'm curious if there's, has a change in diet ever been used to like a ketogenic diet?
Good question.
Actually, excellent question. Actually, the ketogenic diet, which is very trendy right now, and the different types of ketogenic diets, did you know that it started with patients who have epilepsy? Did you know that?
I didn't know that.
That's how it started. It all started with epilepsy.
Really?
So, yes.
So there's something about carbs that.
No, well, there are a variety of theories. I mean, one of them is that in the Middle Ages, and this is one of the stories, but there are other patients or individuals who had seizures tended to be put aside and hidden and sometimes placed to starvation. They would not be fed. And they found that some of these will have improvement in their seizures. And so this was revisited with the ketogenic diet. This is one of the stories, but it's just an interesting phenomenon how the mechanism of ketosis-induced ketosis from starvation will cause the seizures to be better controlled, sometimes stop or better controlled at least. But it's beyond just you have to reach a state of ketosis, and it has to be done medically followed, because we have to make sure that individuals who follow this diet, especially the ketogenic diet, which is more restrictive than the other diets we use. There's modified Atkins diets. There are a variety of diets that we could use, but it's not for. It may not work for everyone who has epilepsy, but it's always worth trying in certain cases.
But essentially, you're pulling out a lot of the complex carbs, and I mean, we're talking about a typical.
Basically, it's a fat-based diet. So
Right.
it's very difficult. The pure ketogenic, it's a very difficult diet to follow with measurements, and they're restrictive. But then there are modified different other types of diets. But I'm glad you mentioned that but I just wanted to mention that, see, the world of epilepsy has brought something that everybody else is using without knowing, that this came from.
Well, it's just fascinating that it actually helps epileptics. That's
epilepsy patients. Or epilepsy patients.
Epilepsy, okay, epilepsy
Sorry,
patients.
I have to.
Yeah, I mean, but it's fascinating that just changing it in that fashion.
Yeah.
I would have thought something like, well, I'm not doing refined sugar would help.
Yeah.
Because it seems a lot of times like kids get so hyped up on that, it's hard to tell the difference between, them having a seizure and they're just acting crazy because they ate a pint of Ben & Jerry's or something.
Oh, no. Yeah, it's still different. It's very different. Sometimes they're just being children.
Right, yeah. No, that's So now, do you suggest that to your patients that they
Some
should?
individuals, and some patients, I think nowadays with there's so much information out there, some patients will come, they're already informed about what's out there. They have investigated. Actually, some individuals, they're their best advocates, or their families are their best advocates, and they'll research, and sometimes they, well, doctor, would that be an option? For some, it may be an option. For others, they may not be. But also, we have to discuss with them the restrictions if we do a pure ketogenic diet. It has to be followed as well to make sure that the individual is getting the right nutrients as well. They're not becoming deficient because it's a very restricted diet.
Yeah.
But again, there are other diets that we could offer. There are medications.
But
stimulation
ketogenic
surgery,
tends to work best.
in certain type of epilepsies.
Certain types.
And it's in certain type of epilepsy, and we can always.
Do you see epilepsy in the same proportions cross-culturally? I mean, if we went to Australia, we'd see the same, like you said, 1 in 24.
Yeah, I
Right.
don't know what in Australia is there 1 in 26.
Or 1 in 26.
What is their frequency? But we know that it affects certain categories of individuals more than others. Also socioeconomically, low tend to be more affected. There are some, especially like certain areas, maybe if there is more a genetic predisposition, and closer.
I suspend
We tend
the
to see
gene
sometimes
pool
the whole family, the whole family or area affected.
So there must
African
be.
Americans tend to be more affected
Really?
overall than, so there are differences sometimes that we can, find, but it can affect anyone at any age.
Yeah. But certain populations just have more
Sometimes,
due to
yeah.
stress or socioeconomic or.
Stress, it's an interesting one. Stress can cause a lot of bad things. People who have seizures can have more seizures just because of a lot of stress all of a sudden, for instance. But stress by itself won't cause epilepsy by itself.
Right. I mean,
Some people who are,
stress over a long period of time leading to severe anxiety.
It can
might
cause a lot of bad things.
trigger
Stress
it.
is not,
Sure.
So,
Yeah, it's an equal opportunity killer.
yeah. Having seizures is stressful too, so it is, having
Sure.
epilepsy, so it just.
Kind of gone through a process there. Absolutely.
The other thing I was curious about was CBD oil.
Interesting.
Yeah. So what's
Medial.
Yeah. So what's the?
So that's an interesting thing. There is only one FDA, by the way, approved CBD oil. Just one. So whatever it's out there is not FDA approved. The one that's prescribed is FDA approved, and it's approved for epilepsy. So it's approved for 2 types of epilepsies. Lennox-Gastaut syndrome and Dravet syndrome. So that's how it was studied. That's how the FDA required to study CBD oil in these 2 categories of types of epilepsies. So are usually children with severe types of epilepsy. So it does improve. There are some stories where individuals have become seizure-free. They're very few. So I think it has a place. It's worth trying, but it's worth trying the approved FDA one when it's medically prescribed in the right setting.
Were those, when a drug goes through approval with FDA, is it just because there has been a study for that drug?
Yes, absolutely, yeah.
So, I mean, because you could infer that it would work elsewhere, but it's.
And plus it has to be done, like, for instance, the CBD oil that's out there, there is no regulation, so it becomes a supplement, it's not regulated. And without getting into the CBD, politics, it's, but anyway, so for
That's what I was
epilepsy.
hoping for.
Yeah, well, I know, we can. There is,
we really don't have to.
there is just one type that's FDA approved, and again approved for 2 types of epileptic syndromes. Sometimes we prescribe it off-label, but it's with prescription. And
under doctor's care, really
yes,
watching
absolutely, and watched, because it has side effects. It has, because it is a medication. At the end of the day, it is a medication. Now, you asked a very good question regarding what is the process and the steps for FDA approval. Is that right? Is it, Chip, something similar?
What you said a minute ago about the 2 types of epilepsy that the drugs were
because
for.
they've been studied that
Because they're
way.
being studied,
So
right.
the FDA, so there are several phases, and I'm just going to simplify this, but there are several phases before a medication or a molecule gets approved by the FDA. The phase 1 is when we try the medicine on volunteers who don't have the condition, just to make sure it's safe. So it's very few individuals who will try it. And then if we found that it's safe, then it goes to the phase 2 trial. And the phase 2, it's usually in patients who have, or individuals who have the condition, for instance, epilepsy. It could be any other different conditions, but since we're speaking about epilepsy, so that individuals who have the condition, but it's a small number of individuals, but they have the condition. So we want to make sure that it's safe, but also that it's effective against that condition.
So the first group is not really a control, rather
The first one is like
it is
to
just
make
a
sure
safety
it's
measure.
like a safety, measure.
Gotcha, okay.
The second one is the group has the condition, and then the phase 3 trial is usually the one before FDA approval. The phase 3 is again individuals who have the condition, but a larger number of individuals. So we look at again safety. We always look at safety, and also how is affecting the condition. For instance, for seizures, is it really dropping the number of seizures significantly to show that it's better than placebo?
Right.
Because in every study, when we do, especially for the phase 2 and 3, when we study a molecule, we want to make sure that that molecule is better than placebo. So the first phase of the study, for a few weeks, patients are randomized. That means we select one group, not the providers. They're randomly selected because we don't know, we're blinded as providers, as
Double blind
investigators.
study.
We are blinded. The patients who have the condition is blinded. We don't know what they're getting. We know the pills that they're getting are similar, the placebo and the active drug. And then for a few weeks, a subset is getting the placebo, a subset is getting the active drug, and then it's open label. Then we go to the open label phase where everybody who stays in the study, because they haven't developed significant side effects or no side effects, they continue the study until FDA approval. And then they get the open label. That means we know that they're getting the active molecule. But we want to always compare. I mean, I think it's worth knowing if the medicine that you're going to prescribe or that's going to be FDA approved, is it better than placebo? Is that right? So everybody at the end of the day, if they continue the study, will end up getting the active drug.
But only after going through the 3 phases in the control groups involved.
Yeah, and then and in comparison with placebo to make sure that it's really more than nothing. Is that right? That the active drug is better than nothing. We have to have that control.
I'm sure whilst
Because otherwise we can say, we all can have a placebo effect without, it's like, I'm getting treated, so I'm feeling better already. Is that right?
I was in the placebo group. I feel a lot better.
Yeah, I feel better.
Great, the placebo worked.
Yeah,
Let's just keep believing that, and you're fine.
Yeah, but so this is the process. And then we have the phase 4, but the phase 4 trials is after the drug or the device has been FDA approved.
We're going to take a short commercial break. We'll be right back with Dr. Miriam Bensalem-Owen. Hello, I'm Chip Sebastian. I am the co-host of Sebastian and Sierp. If you've been liking the shows, please click like down below. And if you want to subscribe to our YouTube channel, jump on over to YouTube, click subscribe, and you will get the most recent episodes of our show where we're interviewing all kinds of great and interesting people. So we're looking forward to a lot more shows. Stay tuned. It's rolling. Just begun.
I'm going to quiz you fun facts.
Oh, yeah, you do your quiz. That'll be
I'm
fun.
going to do the, let's see.
Goody, I get a quiz.
Who has epilepsy, so I'm going to ask, okay.
Ask Aaron the first one, because you asked me the last one.
I have to ask you.
We'll decide later whether or not
Epilepsy.
to edit it
Well,
out.
do you have a question you want me to ask you? Do you have
Sure,
the
go
answer?
ahead.
Actually, we need a buzzer here to see who answers first.
Oh, yes, let's do that. Okay, you raise your hands.
Okay, raise our hands. This is great. It's just like being back in
Okay.
school.
Yeah, let's see if I can pull, okay. We can do in antiquity, but we can do in, ooh.
I know you're going to ask about Julius Caesar. I know he had them.
Preemptive.
Yeah. Well.
I could have won that
No,
question
that's the
too.
question.
I could have hit the
Are
buzzer.
we recording? Are you want to
Yeah, we're
record?
recording.
Are we recording?
Yeah, we're recording.
Oh,
Go
I'm
ahead.
sorry.
No,
Well,
you're
then,
fine.
No, we're fine.
I was gonna pull, okay. So, we're starting now? Can I ask you a question?
Sure.
Can
I'd love that.
Very good. So I will ask you a couple of questions, and if you both have the answer, I'm gonna go with the one who raises his hand first.
Oh,
Okay, very good. Can you think of any celebrities who have epilepsy?
besides the guy on Alias you mentioned?
Yeah, he doesn't. His son has.
Or his son, yeah, you said his son. So he would not be
doing a
one.
fantastic job, raising epilepsy awareness.
Can't think of a single one.
No, nothing's coming to mind.
Okay. Well, there was a rapper, Lil Wayne.
Lil Wayne, okay. I've heard of Lil Wayne, yeah.
There was another singer actually who had epilepsy. No? Prince? You haven't done your homework.
I didn't know Prince was
Prince had childhood epilepsy, childhood seizures.
Oh, okay.
And it did affect him quite a bit. It did affect him.
Really?
But he decided it's not going to put him down, and he just
Trudge around.
had a wonderful career and wonderful,
Wow.
wonderful great. Let's see here. You mentioned somebody who had epilepsy. Is that right? Somebody from the past.
Should I say the name?
Yes.
Julius Caesar?
Yes.
Yeah.
We're good.
Good. Excellent.
Well, I guess.
Good. Oh, you're good. We're good.
Would he
Excellent.
be probably the most famous example from antiquity? Or?
From antiquity, there was even Alexander the Great. There was some mention that he may have had, but it's tough because they could have had post-traumatic epilepsy. Those are warriors.
Sure.
Maybe their cause of epilepsy was post-traumatic.
Mm-hmm.
By the way, in about 70%, 50 to 70% of individuals who have epilepsy, we don't find a cause. It doesn't mean that there isn't a cause. It means most likely that we can't find a cause with the means we have now. Maybe in 5-10 years from now, with better technology, better genetic testing, we may be able to determine why they're having seizures. But so a lot of work.
Do you ever see that as a potential ethical problem in the future? Because right now we're at a point where you could do a cheek swab and send it off and find out your DNA enough to where you're like, well, I know I'm from this region originally. I don't know when my people went from here to there, but I know I'm from that region.
Yes, yeah.
And so, like say for instance, you have that technology available and you're required to give a DNA sample prior to getting insurance or working somewhere.
But that would be very unethical.
Yeah, it would. But
unethical. I mean, there are laws, federal laws, that prohibit from discrimination with anyone who has a disability. So, so people have to be mindful and careful with that.
But I could see. I mean, with discrimination, it's an obvious thing. In the sense of.
But even with insurance, it's a discrimination if you ask, the insurance asks you, and they decide not to cover you because you have a condition like epilepsy.
Right. But do you feel that insurance companies would turn people down and say it was for another reason, even though it really was because they had this?
I don't know. Again, I don't want to get into that, but I think using it that way would be very, very, very unethical.
Right.
Because we don't choose to have a medical condition.
Well, no, of course.
I mean, sometimes the things that we do upon ourselves, but
we don't choose our race either. But
that's true. But we don't. I mean, of course, if you get into fights and you had a head trauma and then you have epilepsy, but again, I don't think we should be here to support each other if we can.
Would you
sometimes
be able to
people do things. Yeah, people do things.
Oh yeah.
I'm glad you did
I didn't
that
know
because
that
it's all about actually. I think raising awareness, and making sure people who have epilepsy.
When that happened at scout camp with that guy I was talking about, I mean, there were 2 or 3 people there that were like, "Hey, run, get a spoon." This has been like 1982 or something. This happened.
It's
been a long
frequently
time
done,
ago.
But now, even now, I mean, you may have some families that don't know what
We
to do.
actually had a guy at work that had one not that long ago.
Is that right?
And it was the first one he had ever had. He's probably in his mid-30s. And he now wears kind of like dark.
Oh, because he thinks it's light induced,
Right.
So there's there's photosensitive epilepsy, but not everybody with epilepsy has seizures induced with floating lights, with certain frequencies. Pokemon, there was a big article with a Pokemon, there was I forgot which year, I have to look back to refresh my memory about the year. They released this game, Pokemon game.
Oh, yeah.
And they had these frequencies. So now everybody that does games have to follow these regulations. Because it affected, I have to pull the number, an amazing number of kids, mostly, that were not known to have epilepsy. but it causes and triggers seizures at frequency.
Mhm.
So that's why now in video games, when you purchase a game, there's if you have epilepsy, speak to your, it may not be, or
Usually
seizures,
there's a warning screen
Yeah.
when you start a game. that says,
Absolutely, yeah.
it's been used.
But not everybody, again, because they don't know who has photosensitive epilepsy. There's so many types. Just to give you an idea, there are epilepsies, writing epilepsy. You start writing and it causes a seizure. It's so rare. Those are reflex epilepsies. I have patients who have epilepsy. Those are rare types. A certain sound will trigger an epileptic seizure. Like when I was in fellowship, I have a patient who would listen to Barbara Streisand, and each time she hears her singing, it will cause a seizure. But just it will hit certain tonalities that will, trigger that. But not everybody will have this type of seizures. There are very rare types of epilepsies, the reflex epilepsies. But photosensitive is one type of reflex. I mean, sometimes it's whatever caused the intellectual disability that will cause epilepsy, but sometimes just having seizures can also, affect memory, affect cognitive, especially when they're happens in childhood.
Mm-hmm.
The brain is like developing, and you're just like boom, boom. It's like having under attack all the time with the seizures, so they can't develop well.
Yeah, that's just so odd.
But I have patients, families that just break, couples. You have a child that's sick, then the couple just because it puts a lot of strain on the whole.
Sure.
You can't go to work. You're always worried. It just causes.
Yeah, it's like having
a sick child. Any
Most people don't think about the severity.
Oh, or any chronic condition, how it affects the whole family, the dynamic. It's totally messed up.
Go ahead.
No, you go ahead, please.
Just like we were talking about earlier about, it being disregarded in some sense compared to Parkinson's or multiple sclerosis or some other neurological disease, but I feel like that's mainly because those are perceived as being more severe.
Oh,
because of,
yeah.
what I mean?
Yeah, I'll tell you because
Being
with
fatal
seizures,
all the time.
well, they're not fatal actually.
Well, Parkinson's and
It's
multiple
not fatal.
sclerosis.
They're
No.
not fatal.
Parkinson's?
See, that's always been my perception of both, especially Lou Gehrig.
Epilepsy, Lou Gehrig is
It's
fatal.
fatal.
Yeah, Lou Gehrig, it's
ALS.
devastating, but it's not frequent at all. But I think what happened with Lou Gehrig is that Lou Gehrig had
Right,
it,
the actual
and it raised awareness. Parkinson's disease, what's his name has it?
Michael J. Fox.
Yeah. And he raised awareness. So I went to the Academy of Neurology, our annual meeting, and he came to speak. But you have these, and plus he can't hide it. I
Sure.
mean, when he was speaking, he was having actually side effects from his medicines. I think he took too much to be able to give the talk. So he was dyskinetic. So he was like having all these movements that were not the Parkinson's, but a side effect from the medication. But with epilepsy, actually, some individuals, you will never know they have seizures until they have one.
Right.
So why would they?
So they can appear normal.
So why would they, mention it? I mean, I have one of the, and it can affect anyone, like Chief Justice Roberts has epilepsy.
Really?
Yeah. So remember when he had one of the seizures, it was public, he was playing golf and he had a seizure, it was 3 years ago, like maybe, 12 years ago or something like that. So they asked me to speak, to comment about him, like UK, they had a thing with one of the news outlets, they was like, oh, he just had a seizure, can you comment? Because everybody wanted to know what happened. And of course, he's not my patient, so I can't comment about what caused him, but I had to discuss about seizures in general. But, so you have some people you would never know, like Harrison Ford. He doesn't have epilepsy, but his daughter has epilepsy. They never spoke about it, but he started speaking about it. And I'll send you all the links, I think it's interesting, and thanks for giving me the opportunity to speak about seizures.
Sure.
So he spoke once his daughter became seizure-free after surgery.
Okay.
And then, because I think he probably didn't want her to be affected, whatever, but, he spoke about it. But it affects so many people,
Well, it was interesting you said that about Parkinson's too, because like a friend of mine, he had Parkinson's for years and then he passed on.
Yeah, but he won't die from Parkinson's. He may die maybe from complications. But people who have Parkinson's, most of the time, sometimes it affects young people, but most of the time, it's a neurodegenerative condition, which is sad. I'm not. But they may die from old age, from other complications, but the Parkinson's itself won't lead to death. Does it make sense?
Yeah.
Yeah.
But it can
The
set
multiple sclerosis, the same thing, won't lead to death. It will to significant disability, they may be wheelchair bound. But we have patients with epilepsy who are wheelchair bound, the cognitively affected from the seizures, whatever. And actually there is this misconception that somebody who has epilepsy severe, they're all wheelchair bound. you can't come to my clinic because of patient confidentiality, but I have some patients, you would see them and have girls that are like, they look like, models, but they don't want to speak about it. So I have one of them, she was doing the Kentucky whatever, Miss Kentucky whatever. And I said, well, great. I was like, oh, can you speak about epilepsy on your platform? No, she decided, which is great, but she decided to speak about babies, from March of Dying, which is fine, which is fine, but see, they don't want to speak about it, So the ones who are brave enough, they speak, I'm like, great, because it raises awareness. It raises awareness, yeah. Because everybody wants to do the march, which is great for the March of Dying, but I'm like, gosh, you have epilepsy, Because we can, as providers, as physicians, we can try to speak about it, but I tell patients it's up to them. It's about them to go and speak about it. So Greg Grimberg, actually, what he did, I have to send you a talk about it, the organization that he set up. He a lot of actors like Harrison Ford spoke about it, So he tried with his colleagues to kind of interview them to speak, raise awareness about it.
Yeah, that's weird that people kind of put it in shadow or hide it like that.
It is because it is scary. It is.
Hey, so listen, everybody. Thank you so much for tuning in to Sebastian and Sierp. It's been a wonderful episode with Meriem Bensalem-Owen, Dr. Meriem Bensalem-Owen at the University of Kentucky. And if you're interested in contacting her, please, what's the best contact for you?
I'm going to give a couple of contact numbers. So.
Yeah, especially for funding. If you want to contact her for funding, that's perfect. Yeah.
859-218-5045 or 859-218-5053. So I'm going to repeat. The first number is 859-218-5045. And the second number, which is also Rachel's number, I mentioned Rachel Ward-Mitchell, our nurse coordinator. The first number is from Micah, Micah Philpott, who is our administrative coordinator for appointments, for instance, and for medically related questions or to join the support group, the epilepsy support group. The second number is Rachel's number. It's 859-218-5053. Again, 859-218-5053.
Then do you have email that people, or do you prefer phone?
The phone will be
okay. So contact her by phone with funding, with questions about funding, anything related to funding. Just contact her. All right, that's what
not just funding.
No, you can talk to her about anything.
If we can, if we can help, my team and I will be happy to.
Hello, I'm Chip Sebastian. I am the co-host of Sebastian and Sierp. If you've been liking the shows, please click like down below. And if you want to subscribe to our YouTube channel, jump on over to YouTube, click subscribe, and you will get the most recent episodes of our show where we're interviewing all kinds of great and interesting people. So we're looking forward to a lot more shows. Stay tuned. It's rolling. Just begun.